Hi, everyone. Thank you for coming. We have a couple more minutes till we start. And so we'll wait for Dr. Jackman to arrive and then we'll get going. Hi, everyone. We are going to go ahead and get started. Give folks a second to get their computers set up, coming off video so we can see your lovely faces. Give us 1 second. We are going to resolve this tech issue. Thank you. Okay, you should be able to come off video now. Or on video, I should say. Fabulous. Nothing like a little virtual glitch to get us going. I'm waiting for Dr. Jackman and Senator Payano. Welcome, welcome. Fabulous, fabulous. Well, thank you all for taking some time out of your day to spend a portion of it with us. Welcome to everyone to NAMI Massachusetts 2023 Advocacy Day. If you are here this morning, welcome back. And if this is your first time with us today, again, I will say welcome. I am excited for this topic, promoting mental health equity in Massachusetts. I'm excited to be your moderator for today. I'm Dr. Myisha Rodrigues, Executive Director here at NAMI Mass, and we're going to jump right in with panelist introductions. I'm even more excited about the folks who have chosen and agreed to spend time with us and share their expertise and perspectives. We will just go in order of the way that I see you on my screen for ease of navigating this virtual world. And again, just as a friendly reminder, I ask that you share your name, where you work, your role and or roles, as I know some of you have many. And if you can finish the prompt, I am passionate about mental health equity because. Again, if you can share your name, where you work, your role or roles, and finish the prompt. I am passionate about mental health equity because. And the first person I see is Miss Lee.
Hi, everyone. My name is Heidi HyunJin Lee. I'm a medical case manager for Boston Healthcare for the Homeless program and former high school art teacher and curriculum developer, and also a community organizer for our program that was called Common Art, an art program for those experiencing homelessness in Boston.
Thank you. Next, Mr. Curry.
Good afternoon. Michael Curry, President and CEO of the Massachusetts League of Community Health Centers, which is an association that represents 52 health center organizations across the Commonwealth, over 1 million patients practicing out of over 300 practice sites. I also wear other hats, as you said, Dr. President, former president of the Boston NAACP, of course, we address and discussed many of these equity issues, and on the national board of the NAACP, and I chair the national board's advocacy and policy committee, which of course includes health and equity as a major priority for the organization. So glad to be with you.
Thank you. Next, I have Dr. Simon.
Yep. Hey, so Dr. Captain Simon, currently the Chief Behavioral Health Officer for the City of Boston. When I'm not wearing that hat, or while I am wearing that hat, I'm also a child and adolescent psychiatrist and addiction medicine physician at Boston Children's Hospital. And there are other hats. But in reference to what makes me excited, I think that's the question, or what are you excited about in terms of mental health equity, behavioral health equity? I think we're in a very unique space and time right now, particularly within Massachusetts, where we have a number of initiatives coming from the prior administration, the new administration, behavioral health roadmap, CBHCs, behavioral helpline. So there are a lot of activities happening that I'm sure we'll touch on. So that's what makes me excited, because communities that Michael Carey's Mass League is a part of, we get to be intimately connected. Same thing with Miss Lee, reaching communities that classically, unfortunately, have been underserved. So that's what makes me excited.
Thank you. Dr. Jackman.
Hello, so wonderful to be here. Thank you for inviting me. So I am Dr. Charmain Jackman. I am licensed psychologist in Massachusetts and Rhode Island, and I am the founder and CEO of InnoPsych, Inc. And our goal is to disrupt racial inequities in mental health. And we do that through a number of programs, but most notably through our Therapist of Color Directory and emotional well-being services that we offer to communities and organizations. I am passionate about mental health equity because, like Dr. Simon said, this is the perfect time for this topic. And I think for me, specifically, it's about lifting up the voices and experiences of people who have not traditionally tapped into mental health or seen mental health as something for them. And I'm just excited that people are recognizing that they deserve healing and that healing is a necessity in these times.
Yes, healing is a necessity. And last but certainly not least, Senator Payano.
Good afternoon, everybody. Senator Pavel Payano. I am a newly elected state senator representing Lawrence, Methuen, and Haverhill. I'm going to be sitting, one of my committees is on public health. Reason I'm excited to be here and excited to do this work is, I approach my advocacy with a certain sense of urgency. My community has been, we're dealing with issues of obesity, issues of diabetes. Literally, a short while ago, as I was walking out of the supermarket, I was talking to an individual that was telling me, late 50s, how he just had a heart attack. So it's these are issues that are affecting my community deeply, and I want to move the needle a little bit to make sure we're saving lives.
Thank you, thank you, thank you, thank you. Oh, yes, Heidi, yes, you can.
Sorry about that. I was a little nervous being the first person.
It's okay.
So it took me a while to think about that, but my passion is actually combined with just my personal lived experience with having lost so many people, so many friends, community members to suicide, homelessness, trauma, and substance use. And so that is why I am doing what I'm doing. Thank you.
Thank you for sharing that and for circling back. So let's jump into the first question. So we would love to know, what are your perspectives on how we can amplify the voices and needs of historically marginalized communities within our behavioral health system? I'll ask it again. How can we amplify the voices and needs of historically marginalized communities within our behavioral health system? Feel free to unmute and answer in whatever order you please.
So I'll jump in.
Smiles I see on this right
And-
now.
So I think, one, I appreciate the question. So again, how is it that we kind of amplify historically underserved, marginalized voices? So I think this panel is a very good demonstration, in part, the diversity of the panel itself. And so when diverse perspectives are at the respective quote unquote table and have influence in terms of where resources are allocated, I think that that's important. So for instance, Senator Payano, you mentioned Haverhill, and I think you said Methuen too. I've happened to have provided psychiatric services in hospitals, Holy Family System in Methuen and Haverhill. And it is an area that classically they don't get the type of services that other spaces do in terms of the metro area, right? So at the state level, undoubtedly, there'd hopefully be somebody like a senator like Pavel who can voice the concerns of his constituents. For Michael, it's voicing what his members and CEOs are saying about East Boston versus a clinic that's in, or a community center that's in the central part of the state. So I think being intentional about us representing who we know and we're very comfortable with. So when I go to, for instance, I'm just plugging a whole bunch of community health. When I go to Whittier Street, Mattapan Center, South Jamaica, like I feel very comfortable in that space, because when I look at the constituents that are there, the residents that are there, they look like me, they look like my aunt, they look like my uncle. So I think that's where, in my role in the city of Boston, we've been creative in terms of intentionally, how do we reach and make sure that those who classically don't know about the grant or don't know about the RFP or all the bids that are out there, we try to make sure that we are reaching out to them. So I think exactly what this forum is in our respective district, let alone region, let alone state, is what's important.
Maybe to jump in there, just first and foremost, credit to NAMI and the tremendous work that I've had a chance to see them do over many years to elevate these issues and to make sure that we were convening in a way to draw our collective resources and our attention to these issues. I think it's critical that we support NAMI, especially with their legislative and their advocacy agenda within government, particularly state legislature. That being said, I also wanted to do what Heidi did, is do my responsibility of saying what my passion is around around equity in the mental health space, because I didn't do that earlier, which is how critically important equity is true for mental health equity as well, which is people are dying. And that sounds really exaggerated if people don't really understand the connection of these issues. But people who aren't mentally well are not healthy. And when you're not healthy, you can die. You can live shorter lives, and you could be gone too soon and be sicker. So whether it's the motive appeal of addressing the mental health crisis that is having people suffer longer or die sooner, or the cost implications that, as I have lifted up recently in other panels that I serve on, pay now or pay greater later. If we invest up front that we don't pay for them in the ER, that's mental health as well, then they're not inpatient as long, that's mental health as well. I think to your question, doctor, I think the critical piece is that everyone's talking about participatory, right? They're talking about participatory research, they're talking about how do you engage communities, how do you understand what they need, nothing about us without us. I love that we're having all those conversations. Again, mental health is no exception. How do we go to communities that are already dealing with our people? And Dr. Simon spoke to that. There are organizations, health centers and others that are already dealing with our communities, that know the languages they speak, the conditions they face, can speak to them in a cultural way with some cultural competence around their circumstances, and then provide them the services when and where they need them. That's where we meet vulnerable people, is whether we can tailor what we do to what they need and get it to them in a timely way. And I think we're in the movement of doing that. But I think Massachusetts should be leading in that effort and not waiting for someone else to lead. This is our opportunity to really deliver on mental health parity and mental health access in the way that we envisioned it.
And, you know, what I would add to that is, one of the things that we have to think about is sort of like, what are the other things that affect someone's health? You know, I think when we think about health, some of us think about mental health, but I think, you know, there's a focus of this person is sick, and we're not thinking about all these the stresses of struggling to meet just basic necessities, paying rent, putting food on the table, how that affects your health, or even the stress of you know, dealing with just white oppression. I helped this woman find, there was a fire. We couldn't find her an apartment in Lawrence that paid close to what she was paying before. So we got her an apartment in Haverhill, and we were joking around like, hey, we're gonna miss you in Lawrence. And she's like, no, I wanna come back. And I'm like, no, like seriously, we can't find you another more affordable apartment. You got something really good in Haverhill. And she said no, that she wanted to move back to Lawrence because the issue was she felt comfortable being in her community, where she could speak her language, where she felt she could be herself. And, you know, that got me to think about what this, you know, that it's not just the cost of rent, is the communities that you live in. And the other piece I always think about is also, you know, within Lawrence, we have one of the highest uninsured rates in the region. It's 6.5. Our neighbor Andover it's 1.3. So how can we say healthcare is equitable if already a big portion of the community is not receiving care?
I think, you know, I definitely agree with all the points that have been shared. And what I would add to the conversation, you know, it's kind of how we try to approach this piece around the equity and sharing our stories. It's really through a grassroots model. And, you know, I can tell you, I know what the stories are, right? I don't need to do any more research. I don't need to interview any other person. So we know there's a need there. I think the real, you know, one of the real pieces is around the stigma reduction. If people don't have the shame and silence around what they're experiencing, I think they'd be more vocal and advocate more for the services and resources that they need. So I think our goal and our mission is really to continue to reduce that stigma, let people know they're not alone, let people know that having a mental health condition is not, you know, Michael, you shared, you know, people can die. I definitely agree with that, but it doesn't have to be a death sentence. And if we can get people earlier in that chain, focus more on prevention, I think we can save people's lives.
If I may, oh, sorry, were you going to say something? Oh, sorry. Yeah, if I may add, yeah, when I saw the first question, I kind of thought to myself, because, you know, when I speak, even though my position is as a medical case manager, first and foremost, I always speak as a peer, meaning someone with lived experience. And, you know, oftentimes, just in that role as a case manager, who's a peer specialist as well, often working with teams that are mostly clinical. I think that when I see the word amplify voices, my thought goes to amplify. From a scale of 0 to 10, if amplify is like 9, 10, I feel like we would just like to be heard. Thank you. That's like around 2, 3, 4 maybe. And I think that's how I feel we are at least speaking from the perspective of someone who's a chronic long-term patient in the system and now serving in the system as well. And we're thinking about both peer voices and neurodivergent voices who are, we have things like ADA, laws in place, but it doesn't mean that we daily have to fight for the rights. Because even though it's been 33 years since the ADA, I will assure you that people with neurodivergence and, the world is not made for us. Just like in many ways, those who, we don't fit the peg, we have to often yell and scream for basic rights. And same for those. And so the clients that we serve on the harm reduction team are those who struggle with daily traumas from homelessness, a lot of them tenting out on Mass Cast, Atkinson Street, a lot of them struggling with, very severe, conditions related to substance use disorders and mental health, conditions that are all kind of mixed in together. So probably, and, huge range of backgrounds from, how they got to that place. But, marginalized communities, I think about, the people that we serve on a daily basis and how so often it's politicized, how, what their voice is, what they, it's often what we think they want versus what they actually want. They're often not asked the question, what are your dreams? Because oftentimes the question is, have you taken your meds? Or, have you stayed at the hospital? Or have you gone to treatment clinic and all such? So I don't often see this amplifying. And even with the Mental Health Act that Baker put in place recently, I know that's the next question, but, I don't, it's been 33 years since ADA, and I expect that it's going to be another couple of decades until mental health, those with lived experience voices are actually going to be amplified.
Thank you for sharing that. Dr. Simon, were you about to jump in?
Yeah, no, I greatly appreciate Ms. Lee's comments here. And Senator Payano, so Senator Payano is highlighting like the social determinants of mental health, right? So before going to that clinic, it is like, do you have the secure housing? Do you have the access to educational resources, to food? And oftentimes within certain communities, there's a lack of access to those things. Well, yes, the downstream is likely going to be dysfunction in relationship to whatever we're calling behavioral or mental health, let alone for persons who may be born neurodivergent or born predisposed to being at a risk of having a mental health condition. And so it is notable that for certain organizations, like Healthcare for the Homeless, and in some institutions, they really do a good job of trying to help people think about not just did you take the medication, but what else do you have going on? I think for myself, when I looked at fields to go into, one of the reasons I liked psychiatry was it was the one field, it was like a mandate and a requirement to think about someone's whole life. I could be my wife's a internist. I could think specifically about like kidney disease, but I may not actually have to think about many other things. But with mental health, it's like, well, how is work? How is school? How are your relationships? What is the housing situation? And so unfortunately, because of dynamics that exist outside the healthcare system, we start to get siloed into specialization in terms of like, oh, well, you're the psychiatrist, so you just do just the medication. I'm like, whoa, hold on. Yes, I can prescribe medications, but I actually would love to know more about the challenges that are going on, because I think I'm able to help navigate to the person, the case manager, or the system that could be helpful. So just wanted to amplify or echo what Ms. Lee is noting, because it does happen where it becomes just a 15-minute chat. I'm like, 15 minutes. People are just getting comfortable at 15 minutes. So just echoing the comments made.
Thank you for sharing that. And before we shift to the next question, I feel like some of the things that I'm hearing are, one, to kind of move backwards, being able to disrupt the norm, right? We kind of get in this routine of we come in, we have our 15 minutes, our 30 minutes, our 45, we keep it moving, right? But being able to kind of reinvent, reimagine what that space looks like, and to reframe that for people, right? To maybe push against their expectations of what's been normed or socialized. Heidi, I really appreciate, the pieces that you named because, unfortunately, whether we whisper or we scream, right, as you mentioned, oftentimes folks within historically marginalized communities still aren't heard. And so I think it is important to be able to make space and room. And I feel like this is what I've heard from a number of our other panelists, right? The importance of creating space for belonging, the importance of creating space for community, not imposing upon, what we think is best, but really listening to, right? Thinking of Senator Payano's example, because ultimately, even though, in taking a more strengths-based and proactive approach, like Dr. Jackman named, the goal is to avoid, or early death. But as, Mr. Curry mentioned, unfortunately, that happens all too often, right? Dr. Simon, what you shared last is the perfect segue into the next question. So that one, the first one got us warmed up a little bit. So curious to know, what programs, policies, or government initiatives do you all believe have barred historically marginalized communities from receiving mental health equity? And what is the resulting impact been? I can repeat it again. What programs, policies, or government initiatives have barred historically marginalized communities from receiving mental health equity, and what has been some of the resulting impact?
I would say, Doctor, that I would probably tie that to broader concerns, right? The pillars to equity generally, or care, or access to care. Let me say it differently. The pillars are access to care, quality of care, the cost of care, and then equity generally, right? And the reality is, in the mental health space, we've had that challenge as well. People can't afford to get the care that they need. So if I'm talking about a mental health visit and I have a copay that I can't afford, then I'm making a conscious choice that I'd rather pay my bills, my other bills, like rent or education, than I pay for that mental health visit. Access, do we have the facilities in our neighborhoods? Do we have the providers in our neighborhoods? Are those providers culturally competent? Are they accessible? As we know, there's a workforce crisis writ large across our healthcare system. So it may take 3, 4, 5, 6 months to get an appointment, which then means I may give up. And then the broader issue around diversity in workforce that we're just starting to pay attention to, which is it took us a pandemic to realize that I may not trust you to tell me I need to get a COVID shot, or to get contact traced, or to get tested, because I don't trust you. And I don't trust you because you're not in my neighborhood, because you can't speak my language, because you don't know my experience, because you don't know J. Marion Sims and Henrietta Lacks, and you're not accepting that there's a taint in our healthcare system as the precursor to then asking me to trust you. And I think we're dealing with this in the mental health space as well: the access, affordability, the cost issues. I think those issues still remain. Credit to all the folks who champion mental health parity, the iterations of mental health parity, and who still identify gaps in that work, NAMI among them. Credit to those people who are saying, hey, like the Health Equity Compact that I serve on to help start with Manny Lopes and from Blue Cross, Jeffrey Sanchez, and Juan LaPera, Rosa from Tufts Medical. We're all championing this movement around health equity, so that we don't miss the moment, as we say, post George Floyd, because the attention is going to turn. So how do we now decide that from now on, we're going to require that we work together to address these mental health inequities, and that we're going to have a conversation around what is the next movement around health reform in Massachusetts that includes mental health to address those things I just talked about, the pillars. And I think that we could miss the moment if we don't have more conversations like this and we don't lock arms like we're doing with Dr. Simon and others on this call to say, how can we do this together? I'm excited about that part of it. We got the right people, right place, right time, like the folks on this call.
You know, I
was gonna jump in.
go ahead, jump in.
I
jump
want to
in.
do a little history lesson because I think this goes way, way back. And if you trace particularly around the anti-Black racism, right? So we have psychiatrists who deemed escaping the plantation a mental health condition, right? So already back there, it's called drapetomania, right? There are ways in which our attempts at freedom were pathologized. And so we can't underscore how that is baked into the systems that we have now and continue to contribute to the inequities. I want to read a quick quote from Bell Hooks. And she says, within white supremacist patriarchal culture, Black people are not supposed to be well. This culture makes wellness a white luxury. So we have narratives where we said healing was not for us. It was a white luxury. And so we've internalized those messages. So from a culture, before we get to programs and policy, we have to look at those cultural messages that really underscore that. I think I continue to add to what Michael shared. I would say our training, I'm trained as a psychologist. And I know I had to unlearn a lot of things that I learned because it didn't really speak to the unique experiences of people that look like me and other BIPOC communities. So we have to look at that training, and I'm excited that there are lots of new training models, for example, liberation psychology, that are really naming the society and the context of which we're in, so we're not pathologizing people's normal reaction to bias and oppression. So I'll leave that there, but I think just noting that history and noting that cultural context is really important.
What I was going to add is all these thoughts. It make me think about how not having access or being afraid that your doctor might not understand who you are or your family, what that does to sort of the mindsets of individuals in my community. We go to a doctor when we're feeling sick. And not just that, sometimes when we're feeling sick, a buddy of mine was having breathing issues. And I said, I think it's time that you talk to your doctor. He's like, what do you mean? I'm not sick, because the mentality is, it's like, you must be on your deathbed in order to go see a doctor. And there's no discussion about ensuring that you're seeing a doctor to do preventative things. So I think about how that affects our overall health when it comes to that. So, so it's a great discussion there. But I also think about how there are certain structural issues that affect the providers. We have a hospital, Lawrence General Hospital, that had one of the biggest inpatient volumes of Medicaid patients. I think last year we had like over 14,000 patients. And one of the big issues that we're dealing with is reimbursement rates. The average commercial reimbursement rate is around 77% to what they get in a hospital gets in Boston. So when a hospital like that is doing this type of work and they're already starting from behind, what does that mean for everybody else? So, but I think one of my hopes is that in the future, we're able to change the mindsets of our community so that they feel like going to the hospital is something good for your health, and not this mentality like, you're going there. This is fear that you go in there healthy and you come out like sick, right? So we have to figure out a way to change that. But I think part of it is ensuring that there's access, that they're getting quality healthcare. And by quality, I just don't mean that the providers are doing a good job, but they're also being culturally competent.
Yeah, can I add on? I love what you just said, Senator. And I think that that idea of avoiding the systems, right? And I think it's by design, and also it's an outcome. So people wait till they're really need resources, particularly think about mental health. BIPOC folks often get treated much later in their journey when they have a mental health condition. And that reinforces that message, right? Because people worry about getting hospitalized, and that reinforces that message if you wait so long. And I really think about, how do we, I think a lot of times we're putting the stigma, when we talk about stigma, right? We're putting the problem in the people who don't access services rather than in the systems that have led to this condition. And so I just really want us to kind of just highlight that. And really, as we think, I'm even checking myself, right? Because I think about it as we're talking, like, but it's not, they're doing what the system has designed. And so how do we, again, think about a system? What do we need to reimagine? Using your word, Dr. Myisha, how do we reimagine these systems in ways that then are caring? I think we also had, I was at a convening last week in New Orleans. It was around the same topic about health equity and mental health equity. And one of the things, and one of the attendees said was that, our healthcare system is actually a sick care system. It benefits from us being sick. So we have to be able to name that. We have to name that. And then we can move, we try to move forward, but we have to name those barriers. And I'm glad that you're helping us to raise that. But if we ignore those barriers, and we pretend somehow it's just the people not getting to the services, right? But when they get there, are the services responsive? Are people welcome them as they enter the office, right? Are they getting shamed within a mental health clinic? I know that's happened.
And
right.
maybe
So we have to name those.
Maybe just a quick point to the senator's earlier point. It's so interesting that we have these conversations around who's sick, right? Because when you're on the medical side, the medical physical health side, we can say you have a cold or you have cancer, right? And all the variations in between. But I don't think people generally, and particularly communities of color, have a sense for what sick is on the mental health side. That it could be like many of us who grew up in the neighborhood I grew up in. I grew up in Roxbury, Lenox Street housing projects. I've seen people shot, stabbed. There are all kind of atrocities and things that we've experienced. The harassment from police officers, the not being hired, the high unemployment rates, the trauma that comes from that experience. When I can tell you, most of us have never gotten care for that, right? But we've never identified it. So we've gone to all of your points, we've become weathered to it. That of course, hey, it's life. Right? It's our circumstance. But the problem is that we don't then translate what the manifestations are in our lives, right? Chronic unemployment, crime, drive-by shootings. When I see a young man who drives down a street corner and can shoot out the car with an automatic weapon and not think about who else can get shot, while I might be angry at him or her, I'm also thinking about mental health because I'm thinking that person didn't get the care they needed. Somebody didn't intervene at the right point to say to that brother, you actually have a mental health problem that we can get you care for this makes you angry, that's making you frustrated, that's making you feel so reckless about your life that you don't even care about mine. So I do think that there's a need to define what unwell is in this mental health space so that my mother, my nephews and nieces, my kids can define it and say, you know what? One interesting thing my son said to me the other day, which even though we talk about this stuff all the time, kind of shocked me. And I found out that he was going to see a mental health provider. And I was a little shocked. I'm like, how do I not know? Like, I got to find out through my mother, his grandmother. And I think that's special though, because I wasn't ashamed of it. I was proud of it. That he knew whatever was going on in his life, he was willing to make that phone call and engage. But most of us don't get there. We become weathered to it. That of course, let's go, I'll pray on it. I'll just get up tomorrow and I'll pull up my pants and just struggle through it. And it shows up somewhere in our lives.
Yeah, I would love to, thank you, Dr. Jackman, for mentioning just kind of what is and what was, because I think that it's hard for us to correct if we don't acknowledge what was that was so destructive in the past. And when we're thinking about policies and programs and government initiatives, so, dealing with like entities like DCF and SSA and, RMV, all the government entities with acronyms on a daily basis. I think that it's challenging not to get jaded by a lot of the things, because I think the improvement part is hard to see sometimes. I mean, I think that I tend to be a glass half full person, but sometimes I come into these spaces with a very personal perspective of having, been sectioned 9 times myself and having experienced what it feels like to be in seclusion rooms and forcibly injected, all these things that we imagine, electroshock therapy, those things hopefully are the minority amongst those who are experiencing chronic mental health conditions, but also just the perspective of targeting policies and such with a more disease model and less of the preventative model. Because I think when we focus on wellness, kind of like what someone mentioned about when it's all of us, that for those with more of a predisposition to mental health conditions, we more easily get triggered by certain stressors. But I think that biology is not as dominant, your genetics, as your social determinants. And I think everybody acknowledges that when all of us have what we need to be our best, then we don't have to get into these situations that are lowercase or uppercase crisis, intervention moments. And at that point, you're just trying to put out the fire. You're not really tackling anything, real. And so I think that when we're thinking of policies, I would just love because I've heard several clinicians talk about the biopsychosocial spiritual model, and I would love to see it actually become praxis, because I see it talked about in theory, but I think that even the spiritual part, I think one example, because I think the stories really do hold a lot of power. And I think about the client that I worked with who came here from Haiti as a refugee due to environmental, I think it was an earthquake, hurricane, and she came here with her boyfriend, and she basically went through a 3-day voodoo ritual by her boyfriend, and she was just almost catatonic, had no affect. And I started working with her. We worked for about 15 months, and I don't know what a voodoo ritual entails. And essentially, she understood about 20% of my English. I don't speak Haitian Creole. I tried to get someone at DCF, she had a baby, 6-month-old baby. She lost custody. And essentially, long story short, I tried to find everyone who could help me to help her to deal with this condition where it was a very spiritual thing that happened to her. But even the Haitian Creole mental health specialist that I found at Boston Healthcare, I was told by this person, who had very genuine desire to help, said, sweetie, this is beyond my pay grade, which, goes to show that the conditions and all the nuances of the things that people experience, if it doesn't fit into the mold of what we're able to, manage, then the service provided can't be quality care, because we do what we can do. And I believe that everybody goes into this field wanting to care and give the best care that they would want for themselves. But I think that we need to really expand, what it means to move beyond even the biopsycho, because there's so much to the complexity of each person. And I love the storyteller, Nigerian storyteller, who told, the danger of telling the single story. And I think that we often do that with each other. And so I would just encourage that the improvement areas that I would love to see is, yes, there is such a shortage of mental health and other clinicians to help the mental health crisis that, Mayor Wu has announced maybe a year or two ago. And, if you're really serious about getting peer specialists and recovery coaches to help in this crisis, then, allow these professions to be sustainable. Don't pay us $13 to $15 an hour and expect a mom like myself with my own neurodivergence and, living with bipolar condition and complex PTSD is a full-time job in itself, along with my son's, ASD. So you pay me $13 to $15 an hour and I'm having a really hard day. It's going to be hard to get myself out of bed for $13 an hour, where the kid down the street at the YMCA, who's a high school grad, is getting paid more than me with an education master's degree. And so these kinds of little things that a lived experience person sees and a policy person does not see, not because they don't want to, but it's hard to see what's down there, So that's what I'd like to add, please.
So everything that everyone is saying is spot on. And I want to highlight just a few things in terms of the lack of pursuit of care or wellness, in part because of history, and whether we're talking about from adolescence or PD to adults, geriatrics, and equity, right? A lot of the times, the way in which the communities that I think we're particularly talking about engage the mental health system is in a crisis, or big C or little c state, yet we, the system, are not well equipped to recognize that weathering, for instance, as Michael mentioned, and do far much more harm in the beginning. It's like the first day. The first day sometimes is the emergency, and it is a really bad place for certain people to show up, because historically, unfortunately, where you're talking about adolescents, adults, neurodivergent, who gets more physically restrained? Persons of color, public insurance. Who gets more chemical restraint or medications? Persons of color, public insurance. And studies after studies show this, right? And so when I show up and I'm the on-call doc, and I appreciate you mentioning Haiti. One, I'm Haitian American, but there was somebody a month ago, I was the on-call doc. On the Friday, the youth showed up, 17-year-old Haitian American male, and a colleague of mine who does not look like any of us here, deemed that the person needed inpatient level of care and sectioned them. So they're in the waiting room. I show up on the Saturday, I hear about all the cases. I'm like, okay, let me go talk with this particular youth. Called the mom. I even called my colleague that the day before saw them to say, hey, how did we come up to inpatient? And they were like, oh, there's a lot of misinformation. I didn't have all the information. I'm like, well, inpatient's like a really high level. How did we get there? And came to find out that there was some miscommunication, in part because the parents said, oh, we wanted an evaluation, right? But getting an evaluation vis-a-vis the emergency room is very different than getting an evaluation because you waited the 3 months, 6 months on an outpatient clinic. So I said, okay, I think there's some miscommunication. Yes, there's some distress, but not, doesn't meet criteria for inpatient. But when I said this to my colleagues, that I was going to discharge somebody who had previously been on a section just 24 hours earlier, you would have thought I told them to, burn the place down. It was like, how are you going to do that, Dr. Simon? I was like, well, you know what? I'll write the note for you. I'll write the note. I'll explain what my disposition is, who I talked to. And I said, some components of this history are accurate, but there are some embellishments. And when we take the whole picture, this person does not need to be hospitalized. And they'll see this writer in clinic on Friday, right? But that's willingness to say, wait, let's look at this differently. And a lot of times our systems, they just operate as a system, and what goes in comes out. And unfortunately, it does hurt, particularly people who are often underinsured or no insured, have some forms of melanin in their skin. And so it does take, again, a panel like this to be overtly calling that out, because like an organization like NAMI, back in the 70s, someone said, look, our sons are not getting the help that they need. We got to do this on our own, right? And so I think this goes back to some of our history in terms of communal organization. Okay, what can we do? Because if we're going to wait for the system to fix it, it's just never going to get fixed. So just wanted to highlight that.
Dr. Simon, you keep coming through with the perfect segues. Before we transition to part B of this question, that does position us to explore improvement areas, I just have to say all of these responses are stirring my spirit. If I had access to confetti and emojis and likes and snaps and all of the things, they would be covering the screen right now. So much of what you've said is just resonating with me. Some of the things that I'm hearing this round are, one, there's the system, big S, little s, and we can't just look at the present, but we have to look at the past, centuries past. And that it's also important for us not just to look at the system, right, but really live in the intersection of what is the impact of the system on the folks that have been marginalized by it, and how has that shaped not just behavior and health, but also beliefs, right? And so what do we then need to do when we talk about community, historical, intergenerational trauma, right? All of that is thread throughout. And so what do we do? What can we do? How do we better position ourselves? You know, taking a lead from Heidi and looking at the word amplify, you know, in this instance, as I look at the word equity, right? Like, you know, implies that we're trying to figure it out with the system that we have, and maybe that's the problem. Because as we have noted, it was never really designed for certain groups of folks anyhow, to succeed and be well. So the second part of this question is, what improvement areas should we focus on then when promoting overall investments in our behavioral health system to create space for historically marginalized communities to be empowered toward greater well-being? And ask it again. What improvement areas should we focus on when promoting overall investments in our behavioral health system to create space for historically marginalized communities to be empowered toward greater well-being?
I can kick us off. So this one, I didn't mention, I also worked at a high school in Boston, and so really was in charge of helping our young people, you know, intervening in kind of crisis situations, but also around the education piece. And so I was recently on a panel, Dr. Simon was also on that panel, where we were actually exploring what would it look like to have a mental health curriculum that started at pre-K and all the way to college and beyond, right? So I look at it through like, how do we develop a program, a curriculum that educates our young people or children, you know, to be able to recognize their feelings, so building that emotional literacy, and then build into that to recognizing signs and symptoms of different mental health conditions through a cultural lens, right? So want to make sure that, because it shows up differently in different cultures, right? Some cultures, they may talk about more the physical complaints. You know, I'm from Barbados, so we talk about not feeling good, right? Having bad feels, right? So how do we translate what people experience within their cultural language into what we might say kind of maybe is in the DSM. But I think that education is really key, because it not only gives people a language, what they're experiencing, but I think the other piece, I think some other folks mentioned this before, it also helps to build that workforce. So we find that BIPOC youth don't get involved in mental health because there's so stigma around it. Heidi, you talked about just the low pay, right? So all of those things, I think really we need to kind of really think about how are we really building a system that's sustainable careers for young people, but also building that emotional literacy so people understand and can communicate what they're experiencing.
Maybe to add, so one is health centers, not all of them, but some have school-based health centers. I think investing in school-based health centers where students can go and get their mental health care needs met are critical. And we've not really invested in that space here and across the country like we should. I co-chaired the governor's healthcare transition team. And one of the conversations we talked about was a moonshot approach to the workforce crisis we're addressing. That is mental health as well. How are we incentivizing a pipeline of strong, culturally competent, along all of the professional type mental health providers that can come into the field, that are diverse, that are women, that are people of color, that are LGBTQ plus IA, and have them come into this space and serve. Three quick initiatives. One, thinking about scale of programs, the Massachusetts MGB, Mass General Brigham had invested some money in the Mass League, the work we do at our health centers, to try to solve and tackle some of these issues. One is the Behavioral Health Workforce Incentive Program. Again, a partnership with MGB, increasing behavioral health access to Black, Indigenous, people of color, communities of color, underserved communities across the state. And that workforce program has provided 21 providers were awarded out of 27 applications. Of the awardees, 6 different race ethnicities are represented, include Afro, Latina, Asian, Native Hawaiian, Pacific Islander, biracial, multiracial, Black, Hispanic, Latino, Spanish, and white. 4 languages are represented, and a total of 82% of BIPOC applicants have been awarded with this funding. This is phenomenal when you can put the resources into places where we create that pipeline. And although this seems like a small feat with the numbers we're talking about, for all of you who are providers, you know what 21 providers, what 21 professionals mean in terms of access. The access is bigger when you think about that. The other is a behavioral health internship pipeline program. 2 years of this program, 75% of their interns identify as BIPOC, 75% speak a language other than English. We're in the 3rd year of that program as of January. $2.2 million was invested by the Scarlet Feather Fund. We often talk about internships where Black and brown folks can't afford to do unpaid internships. That trajectory that wealthier white families have historically has been denied to Black and brown folks with lesser means. So this is just 2 or 3 initiatives that we have. Loan repayment is another one of those. How am I going to pay your debt so that you stay in the communities where we need you, so you don't get distracted or derailed from your career, and we're investing in your potential to serve within communities. I think all of these are tools that we need to spend more money in. And again, pay now or pay greater later, because if we don't have you, all of you on this call that are providers, we're paying for it when we need a patient to see a professional.
I'd love to take a moment to just talk about, I'm going to take a little break from being a Debbie Downer for a second. And so some of the improvements that community members in the grassroots level have made tremendous impact. I'm talking about friends like Toy Burton, who has, started, founded, executive director of Dee Dee's Cry. She did not see people like herself who were suffering and grieving from loss of suicide, so she made it happen. Same thing with the Unity Roxbury Parade. And Laverne Gordon, who as a person, a peer who struggled with DV, was in imminent danger herself, then created her own foundation called Love Life Now. And for those, because I'll tell you, you think it's hard finding a bed, a psychiatric bed, is so much harder finding a DV bed when someone is in imminent danger. And it's just like, you just call Casa Myrna on the hour, every hour, and you hope for a bed. And then the second you ask the client if they want it, then it's gone. So it's like, I love that she created a foundation and like a safety fund. So it would provide 3 to 4 days of hotel nights to just buy some time so we can find him a safe shelter, that kind of thing. Laverne, you're awesome. And, there's, Myisha Deed, Pure Spark, amazing, amazing work. And so many others who are peers in their lived experience, serving those whom, when you're thinking about, I wish I was served this way. Toy thought that, I wish I had that. Don't have it, so going to make it happen. And I love that energy, because oftentimes, and this is not to say that providers, it's their thing to provide us hope, but as a long-term patient, I've come to learn that you have to navigate things yourself, that you are your best advocate, because no one else is going to do that work for you. And they shouldn't either. And I think when we come together as those with lived experience, along with clinicians and others who are in the field and have decision-making power, we can do tremendous things. But, I think that there is so much, like hopelessness when you think about, I know I'm jumping ahead to your final question, but just like thinking about how do we hold on to that hope? Because for long-term patients, those are experiencing all the different, vulnerabilities of substance use or homelessness or all such that makes us so marginalized and unheard. We need to cling to that hope, and we have to do it together, because it's so isolating to do it alone. And it's been so hard during the pandemic to join, voices together, because it's been challenging to be in person. But now is a time, like Michael Curry says, is to ride the wave. And we know that now mental health, wellness is now a thing that everybody is now acknowledging, because who hasn't been depressed in the past 3 years, right? So.
If, I don't know if Senator Payano wanted to share anything, but I'm gonna take an opportunity to share in a little bit more granular detail some of the things that we're doing. And so, sorry, man, I'm going to hijack the screen here. So, at the commission in the city of Boston, so we have a center, the Center for Behavioral Health and Wellness, and this is a center team. And despite being a full team in short duration of time, our efforts are around. There are a lot of activities already happening, right? So you don't need a new center to start doing new activities, but you certainly might be very helpful in terms of coordinating what is happening within the commission of the Boston Public Health, within the city, as well as within communities. So that's what the goal of the center is, like, how do we better coordinate? Now, 3 areas that we have, right? So, and we've been talking about this: increase the diversity of the workforce, widening awareness of resources, and strengthening the training and capacity of individuals. And so for the first one, right, the workforce expansion, we have an RFP that's out. It's already been closed, but we received, I think it was 12 proposals, and there's a team, I'm not within the team that gets to choose, because I have conflicts, but there's a team that's deciding on, okay, who is going to be awardees of this pathway. And specifically within the language, this is where language is very important. We said, Michael mentioned, you can utilize funds for stipends for students that want to go to do LDAC or peer recovery or therapeutic mentor, target specific communities, right? That's 1. 2, the widening the awareness. We have an RP literally closed, I guess, Friday, where I asked procurement, hey, how many applications did we get? And we got 13 applications. And so the team's going to be looking at, okay, who is it that we fund? And this is in reference to the communities that classically need to know this information, don't get the information. So it makes no difference if it says Dr. Simon Clinic, if it's not in Haitian Creole language, or if it's not in Cape Verdean, if it's not in whatever the language is, right? So we really emphasize in the application, in the proposal, please specify how is it that you're going to communicate to the underserved population. And also we want to hear from persons who have the experience. Don't just fill the application with, oh, hey, Dr. Simon's going to do this. No, I want to hear from persons who have had the experience, because how they want to hear the information, it will be more salient. And so that just closed. And then this last one, which would be the capacity, we're actively writing that, so that way, hopefully another greater than 10 proposals come through. So we have an opportunity here to really make a shift, but it's only a small fragment of what has to happen wholly, right? And will say, it is unfair, and I believe this to be true. It's unfair for the 52 like community health centers, right, that have a greater percentage of individuals that have public insurance to bear the weight of seeing those who can't afford to pay out of pocket, right? Yet there's a whole shadow like system that exists of mental health care providers who are available to see people. Oh, but if you can pay it, right? So how do we leverage getting some of those providers to do work, and maybe that isn't a group platform, because it really is unfair. Senator Payano mentioned it. You know, a community health center might have to see literally triple the number of people to make up the payment than an entity that sees, you know, private insurance. They can see a very small number, but they're going to get paid for seeing that small number, where you have this other entity which classically serves BIPOC populations, which what would happen if a clinician's in that environment, I got to see 3 times as many people as my colleague does. So I think what we're doing here and talking about, you know, it is really shifting the system. But so I'm generally excited about where we could be going because of the activities and the faces that I literally see now at tables is very different than what has been in the past.
I gotta say there's not much that I can add to all this, except to say this conversation has really helped me like re-energize. There are times when you are having these discussions and sometimes you feel like folks are not getting it, or you're like, oh, it's gonna take a bit for at least, locally for policymakers to understand. But I think it's important. Me seeing like everybody, having these conversations about how we're all moving the needles all across the state, and I think it's important that we continue to come together to help support one another. And I think that's one of my roles, to try to advocate, see the good things that are happening, and finding ways to getting communities like mine to be able to emulate that. I first started to understand, comprehend a little bit more about this issue when I was a school committee member. This was years ago. I was a school committee member in Lawrence, and I remember that this parent called me up. I took time off of work, picked him up from the mechanic, drove him to his house where his child was there, and they were telling me that the child was being kicked out of school. He got first quarter, second quarter, straight like A's and B's. Third quarters, D's and F's. In my conversation with the young man, I told the parent, I'm like, listen, I'm not a professional, but it sounds like something's going on, and it sounds like your child's depressed. And I remember that the parent was like, what do you mean? How can he be depressed? I bought him Nikes. He has a PlayStation. Like, he just couldn't understand it. And then we go into the school, have a conversation with the principal, and I remember saying, like, how are you kicking him out when he has one more semester left? And they're like, oh yeah, that does make sense. And I'm like, and at what point are you guys gonna assign him a therapist or like someone to have a conversation with the child? Because you don't go from A and B to D's and F. And like I remember the principal being, he's a nice guy. I know him. And he was just like, wow, that sounds like a really good idea. And that's when I realized that we have an issue. We have guidance counselors that unfortunately there's too much work already in their plate, that they're not able to really focus on the youth as they should. And we need individuals within the school. And I like your idea, Dr. Jackman. Let's start that early on. Like, why not? And I think that will help kind of change the mentality of seeking help. And it's one of these things that at least in the Latino community, you can find folks that are extremely educated. My father, very, very educated individual. He doesn't understand therapy. It's just like no amount of discussion is going to get him to get it, because you're just going against all these things that you're not supposed to do. You're not supposed to talk about your family to random people. You're not supposed to show weakness, especially to folks that don't understand your community. So like within a certain generation, there's these hurdles to try to overcome. And I do love the idea of working with our youth, and who knows, maybe the youth are able to change the mindset of the elders. I'll say, like, I'm this close to getting my father to think it's okay to get therapy. At one point I'll get there.
And Doctor, maybe a quick point too, as trends and solutions to this conversation. So one is the groundbreaking work underway around telehealth. What the data is showing us is people, particularly people of color, are accessing mental health services in greater numbers because of the technology. I don't have to leave my house. I don't have to walk into a building and walk into a mental health department and deal with stigma. I can go on in the comforts of my home or in a safe space, and I can engage a provider. So one is that technology, we need to make sure it doesn't leave us behind, right? All the broadband, Wi-Fi issues, the cultural competence in how that technology is made available needs to be unpacked. COVID also taught us something else. We found out that Black and brown folks weren't rushing to get vaccines. And then when we were, they weren't putting them in our neighborhoods, right? To get them. We should apply that same lesson learned to mental health services. Can we bring it to where you are? Black COVID Coalition, La Collaborativa. Can we knock on your door and talk to you about mental health, Senator Payano? Can we talk to your dad? and say, let me just introduce you to this notion that mental health is just like your physical health. It can be a minor thing or it could be a major thing, but you need care on all of that spectrum. And let me talk to you about it. So it's somebody supporting you, Senator Payano. And then how do we mobile vans, right? Fairs on the street that are not just about checking your diabetes or your cancer screenings, but are mental health vans on the street that are doing screenings, that are educating. We're not using the same things we found out what worked in COVID. We're now not applying them to this other space of mental health.
Yeah, I love all of what you said, and I would definitely want to add to the thinking about two things I wanted to respond to. One, how do we expand beyond therapy? And I always say I'm a therapist, so I'm always that's my bias, but I think we also have to expand what mental health resources can offer. So going to a yoga class, right? Because we have to think about mental health on the spectrum, right? From healthy to unhealthy. And how do we take care of our mental health, the healthy parts every day? What are we doing that makes our soul smile, that makes us joyful, right? How are we building in those languages? Resting, right? There's this woman who, Teresa Hurd talked about rest, right? How are we building in, because many of our communities, we're overworked and we're burnt out, right? So that just contributes to the unhealthy thing, unhealthy spectrum. So again, how do we expand that idea of therapy is not, and I say that therapy is not the only thing. So getting physical exercise, yoga, qigong, whatever it is that is connected to that movement. Get involved in arts, creative, again, so all those things that we can do consistently to support our mental health and well-being. And then I'm a proponent of the annual emotional health, mental health checkup, right? The same way we do that for physical health. How do we start to normalize the culture of getting a screen for mental health well-being? So connected to what Michael was saying. And I love that idea about the mobile mental health clinic, because I could see that. I want to drive that van.
Yeah, I mean, just to add to that, so Toya and I are preparing for to present at the suicide prevention, the state one coming up. And one of the big things that we want to target is just how, people of color experience, microaggressions, different things that we have to do to just be human on a day-to-day basis in a very psychosomatic way. And so oftentimes, we experience things on a very physical level, which is very much tied to our mental. And I think that I've heard so many friends who have said that just lifting weights or just doing yoga, like you mentioned, and just those kinds of things where you have trauma built up, the cortisol built up in your system, and you're just releasing it by lifting weights, doing yoga, just getting attached to your head to body again. And for people with PTSD, that's huge. I'm practicing Brazilian Jiu-Jitsu right now, and it's been an amazing, but very, very painful exposure therapy. And I think that when we realize that, at least when we're thinking about just dollar signs, preventative measures are far less costly than if you think about my last hospitalization, I was there for about maybe a little less than a month. It was nearly $50,000. Thank God insurance paid for 90% of it. But believe you me, I'm going to be paying for that 10% through my credit card for a long time. And, I don't quite understand why healthcare has to cost that much. And I don't have any control, or we don't have time to talk about that now. But, I think that we need to realize that if we're really trying to be cost effective on the government and, just systemic and, micro level, that I think we need to think about how it's thinking about wellness. If we think about the RAP plan, wellness recovery action plan, again, another thing created by a peer, that it's so much better to tap to that. So suicide prevention, often it's about what to do when someone is in danger of hurting themselves and others. But let's take a few steps back. How did they get there? And what could we have done, in the small nuclear level and on a bigger level to prevent many of those people who are now in position of Section 12s or 35s from getting there in the first place. And I think that's going to cost, is far less. I was listening to Dr. Reisberg, who, runs the Boston Community Pediatrics, and she was telling me that what she does is provide for her patients anything from pediatric care to helping her older patients get to a college visitation. And I thought that was, oh my God, that's amazing. But why wouldn't we even think to do that? But if you think about her understanding of systemic trauma and generational trauma, and how that all ties in together, and how helping a family who wouldn't be able to do a college visit otherwise is very much tied to health and wellness and mental health as well. And she goes in not just by herself as a pediatrician, but with the psychiatrist to help assess, together. And I think that's an amazing thing that she's doing.
So, Dr. Rodrigues, one of the things that I'm hearing here, and again, I'm gonna steal the screen and highlight. So I would much prefer mental health to not necessarily be coming from a Dr. Jackman or myself, right? And so I took my daughter to Shevu, this is like 2 months ago now. And as I note in the article, and like in the moment, it was so many kids, they were all at like 13 to like 18 in Dorchester, rocking out, particularly when they heard like Little Uzi. For those of y'all who don't know who Little Uzi is, look it up. And I mean, the energy just was, as you mentioned, Dr. Jack, joyful. And I was like, this was joyful. And it's this that should be funded. Shevu and your Boys and Girls Club, your YMCAs should be open longer. People who work there should be paid better, because it's really there that you should be meeting adults who care about you, and you should be able to have the frustration in the moments of embarrassment where you're learning how to manage emotionally and social emotionally, right? And so, yes, it's just a letter, but it was like, hey, Kate, I know you, future. When you think about behavioral health and mental health, it can't only be from the purview of the clinic, because that's not where it happens. Like, and when I talk with youth and families, I'm like, just tell me what's happening after school. And for a lot of communities, particularly communities of color, there's a dearth of activities that youth can be engaged in because of the cost. The camp costs too much, the practice costs too much. And so it's like, if we're able to fund that, and it's interesting, I literally I'm like, ma'am, not that I don't want to see your daughter every 2 weeks, but it would be so much more valuable if your daughter was engaged in writing, yoga, something else with other youth that allows her to see herself in a normalized way. Because anytime she engages with me, she's inherent. I'm the doc. Like, it's not a normalized relationship that a 16-year-old and a child psychiatrist have. Like, yes, I can be helping her, but it'd be so much more valuable for Shevus and others like that I know exist in Boston, if they actually receive support. Because the reality is, what they do is actually behavioral health. So I just had to highlight that.
Thank you for naming that. I know that there is, I want to say NAMI, Georgia and Atlanta, they have a program where they go into barbershops in the city. And they train barbers with counseling skills, because the conversations are happening anyway, right? And so since that is a space of belonging, and since that is a space of community, they saw it fit to be able to just enhance the skills for BIPOC men that are coming into that space to be able to continue to receive support. So I'm 100% in favor of that. I think the other thing that really resonates with me as well, as a clinician who has a background in the performing arts, specifically dance, and has integrated some of those expressive arts and mind-body approaches in my practice and also in my personal life, right? To just help navigate life. I think that there's such great value to recognizing that there isn't just one way. And the other takeaway that I have from what a number of folks have said is the improvements are happening, like the movement has begun. There are folks who, as we've named, Beatty's Cry, Pure Spark, InnoPsych, right? There are folks who have taken it upon themselves to say, you know what? The system wasn't set up, so I'm going to do my own thing, and I'm going to reach out to the folks in my community, right? And help educate others in providing services. I think with that, you know, there are also, and we've named this today too, that there are folks who are now, you know, at the proverbial table, right? Even if we just look at this call today, who are in seats and in spaces to be able to amplify those voices and to be able to speak to, you know, folks that have historically had power in Massachusetts, throughout our country, et cetera, right? And that's also changing the game. I think the only thing that I would add is, as we are showing up and making improvements in these various spaces, it's important that we're not compartmentalized, right, and siloed. And it's important that we're able to link arm in arm. You know, I know NAMI has been doing work for 40 years, and there have been some gaps, right? And so moving forward, conversations like this are just the beginning. I look forward to following up with all of you after this to talk about some of the amazing ideas you've mentioned. But in the meantime, to close us out, and then if we have time for maybe 1 or 2 questions, we'll fit those in. But in the spirit of the way that we began, if you could complete this statement and fill in the blank. The Commonwealth needs to let go of blank to help promote and achieve mental health equity for historically marginalized communities. Again, the Commonwealth needs to let go of blank to help promote and achieve mental health equity for historically marginalized communities. So what is that thing you think the Commonwealth needs to let go of?
Maybe I'll start off, and I probably believe this will probably be echoed by many others. There's many things the Commonwealth needs to let go of, but I would say one that jumps to mind to me is it needs to let go of institutional racism. And in all of its manifestations in society. I think we're, as a society, starting to understand what racism is, that it's not just using the N-word or hanging someone from a tree, and that it could be as simple as who you hire, how you treat a patient, who you give resources to. And once we unpack all of the manifestations of racism in our society, then we can do some real work to give access to the communities that need it most. But I would say that would be racism, institutional racism.
You know, I love that point you made, and that was one of my points, and connected to what Heidi had also talked about in terms of the identity-based stress and trauma that people experience when they just live in their day-to-day lives. But I would say, if I were to craft this sentence, the Commonwealth needs to let go of thinking that they have all the answers. And so how do we, again, tap into the voices of people with lived experience, culturally diverse voices, culturally responsive resources? So just letting go of thinking, you know, the idea that they know it all, and how do we acknowledge different ways of knowing, particularly as it relates to mental health.
Sorry, I didn't want to jump into anyone else's. I really hope for is, I mean, working specifically, because when you're working with homelessness, trauma, mental health, and substance use, I mean, almost always the substance use will dominate the other two. I mean, it all is intertwined. And I think that when it's a chemical battle, you know, I think what I really let go of is kind of, there's been such a war on drugs, and we know how that's played out. And I truly believe that we heal in communities, we heal together, and we struggle to, I've seen it in pockets, but we struggle to raise our children in villages. And it's sad, but I think that, you know, one of the things why people keep coming back, even though the city requires the people who are tenting out to clean out their tents every single day on the weekdays, is yes, because of the substance, but also because in some way that is a safer space than wherever else they came from. So when we're thinking about that, and the incredibly high ACE scores that people are coming from, that experience, and this is some sort of a community for them, as dysfunctional as it is, you know, we have to think about, like, how can we create more better safe spaces? I love how Toya is creating safe space for Black men through some of her summits and some of her, you know, virtual meet groups, but really targeting those who are most unlikely to go to typical therapy or healing spaces in the ways that we have set into the system, and meeting people where they're at in ways that are sustainable for them. And I think that when we, punish people and in consequences, surely, and people will say, I'm so glad that I was Section 35 because it just helped me to realize that I actually want it. And you will hear the stories, and no one's invalidating those stories. But at the same time, we know from data that when we force anyone into doing anything and just pour more shame upon the shame that they already have on themselves about the substance use or other things, it often doesn't lead to lasting results where they see that they're worth that recovery, they're worth that treatment. And so I think a big part of harm reduction, we know as harm reduction team members that that is not the ultimate solution to every single problem. And when it comes to substance use, but we do know that compassion and really seeing people when they feel invisible, that surely does help to humanize the process of, treatment and building relationships and hard-earned trust.
Thank you.
Heidi, originally, I wanted to speak on stigma, which is a part of the conversation we've been having throughout. But I think what you just said really hits home for me. And I think because of this work, I have a better understanding of sort of people's mindset, and I empathize every time I'm having a discussion. I think about even when someone's upset or angry, I think about what made them get to this point. So I'm able to step back and try to figure the person out. But I don't think a lot of people think that way. I think it's hard for folks to empathize with individuals that they don't know, or situations that they've never had to face. It's really difficult for someone to understand what a panic attack is when they never went through a panic attack. And I think there's a piece that you mentioned about being seen, and that I think that is so powerful. And we're seeing across the country these extremely violent acts, and sometimes I wonder, were these individuals ever seen? I was a teacher for Department of Youth Services. Within Department of Youth Services, there were a lot of students that, we were trying to help get their high school diploma. And, you would think like a lot of these kids were very, very smart. Like, kids were smarter than me when it came to math. I was a math IEP teacher. And the way, folks would come and they asked me, well, how were you able to get them to be interested in schooling? And it wasn't because I was a good teacher. It was because I saw them, and I was focusing more on their mental health and making sure that they felt empowered to take this on. And that's what got them sort of in that right path. And so I hope this is not necessarily to remove something, but that all of us are able to see the world with more empathy.
Thank you. And so far, before we have the last one, we have systemic institutionalized racism. We have letting go of things that cause shame and stigma. Dr. Simon.
Yeah, no, so I would say in terms of letting go, I wrote down labels, in part because, and this is not to disagree with anything else that's been said. I think letting go of labels would be very helpful, because sometimes the label itself creates this box that we have to kind of try to operate in. So you were mentioning dance, and I like to bring my kids in. So I bring my daughter to a dance studio. It's in JP every Saturday morning, and they have a little mantra that they say during class, and it's like, oh, this is behavioral health, and would love for them to, kind of view themselves that way and apply for NAMI dollars, SAMHSA dollars, but I don't know if they do. And so one of the things that we're trying to do is, even for those organizations that do apply and may not be awarded, still engage with them to say, hey, you actually still have an application here. Maybe now you get a letter of support from us to something else. So that way, this isn't just like a endpoint. And you just say, oh, well, we didn't get funded. Well, it's me. It's like, no, there's still an opportunity here. I think to Lee's point, or Heidi's point about the conversation, again, the label, right? Substance use, mental health, somehow these are separate. In what world? None, really, but because of policy, they are. I think once we begin to recognize how interconnected all of these things actually are and open up funding for a variety of services, a variety of areas to be at the table integrated, I think that's when we'll see true movement towards equity around mental health, around substance use, with broadly, I just say behavioral health. And so I think the labels is what pigeonholes us to only think about, oh, arts, and so art funding. It's like, yeah, but art funding helps this. Oh, housing, so only housing, well, yeah, but housing is important for this. So to me, it would be figuring out a way to let go of our labels, because in this particular space, it's all included.
If I could just jump in, I'm so sorry, I don't want to dominate. I just want to add in one little thing. There is a doctor who works for Advocates, Dr. Gordon, who did a presentation on open dialogue, and it's something that they use in Finland that is pretty tremendous. And, as a psychiatrist, as a Harvard medical professor in psychiatry, he just kind of says, I'm kind of shameful of my field and what we have done, in that on average, patients who receive psychiatric treatment get, is on average about 25 less years of life. Not so much always because of their condition, but in the treatment that they're receiving. And that's, he kind of calls it appalling. And that what they try to do is use the open dialogue model, where they take, the team that they have. And of course, this is sort of tackling the very thing that makes mental health care for chronic patients so challenging, is the tyranny of time. It's like you said, the 15 minutes in and out, and it makes it so hard to, diagnose slowly or try to assess what's actually going on, as opposed to just the overall symptoms. And I hope that you'll take a look at some of his open dialogue and how that could apply for some place, as progressive as seemingly as Boston is.
Thank you for sharing that resource, Heidi. So we are right at time. We do not have time for questions today, but hopefully, one of the questions we were going to ask was, if you're feeling discouraged because you feel like change is happening too slow or possibly going backwards, right? What say you? And so hopefully some of the things that were shared today can help to, serve as responses, call-in responses to that question, because, there is work being done. And as folks have named, the time is kind of primed for more work to happen and for folks to come together to create increased equity within mental health, and ideally, hopefully, move beyond equity toward liberatory practices and systems. Thank you all, panelists, for your time, your expertise, your perspectives, and sharing space with us. Attendees, I hope that you either learned something new and or had something affirmed and amplified for you. This will be posted on our website so that folks can watch the replay. If you have any questions, please feel free to reach out to folks here at NAMI. And thank you again for your time. Take care, everyone.